Good morning, everyone, and thank you for joining the New England Nursing Home Quality Care Collaborative. My name is Nayara de Oliveira with the New England QIN-QIO. This is the 7th webinar of our 9-month educational series, Navigating Infection Control and Antimicrobial Stewardship in Long-Term Care, brought to you in partnership with the Massachusetts Department of Public Health and Tufts Medical Center. Today's session is Antibiotic Selection, De-Escalation, and Duration. Before we begin today's program, I have a few housekeeping items to review. This webinar will be recorded, and the presentation will be available within a few business days. The phone lines have been muted for the presentation, but we do ask that you also not place your line on hold. Also, if you just joined us as these announcements are being made, please manually mute your line either by pressing *6 on your phone or using your manual mute button. If you have a question at any point throughout the presentation, please enter it into the chat panel to the right of your screen. Please make sure to send your comments to all participants. A lazy Victor from the QIN-QIO team in Massachusetts will be monitoring and responding to questions and comments in chat. He will also have an opportunity to ask questions over the phone at the end of the presentation. Lastly, if you find that the presentation is a little cut off, please use the plus or minus icon in the top right of the presentation window to adjust your screen accordingly. And now, I will turn it over to Melissa Cumming from the Massachusetts Department of Public Health to introduce our first speaker. Melissa?
Thank you, Nayara. This is Melissa Cumming with the Massachusetts Department of Public Health. I'd like to welcome everyone and thank you very much for your commitment and participation in this program. We will have 3 speakers today. The first is Shira Daron. Shira is a physician in the Division of Infectious Diseases at Tufts Medical Center, where she has been the physician head of the Antimicrobial Stewardship program for the last 13 years and is also the associate hospital epidemiologist. Our next speaker will then be Gabriela Andujar-Vasquez. Gabriela is also a physician in the Division of Infectious Diseases at Tufts Medical Center and a member of their Antimicrobial Stewardship team. And she is also a recent recipient of the IDSA and SHEA LEAP Fellowship Award, focusing on leadership in antimicrobial stewardship and public health. And our third speaker today is Kara Bolak. Kara is a pharmacist at Tufts Medical Center and the pharmacist lead for the Antimicrobial Stewardship Program, as well as the infectious diseases pharmacist for the institution. And with that, I will turn things over to our speakers.
Thank you, Melissa. So this is Shira, and today's webinar is titled Antibiotic Selection, De-Escalation, and Duration. And we're going to jump right in with a case. So this is a 68-year-old long-term care resident who developed respiratory symptoms, and a chest X-ray is consistent with pneumonia. So he started on the broad-spectrum antibiotic piperacillin-tazobactam, the brand name is Zosyn, to cover resistant organisms. 2 days later, the sputum culture comes back, and it's growing strep pneumo. The patient responds quickly, so no one narrows the antibiotic. He's doing well. We don't want to mess with success, and so the patient completes a 10-day course of piperacillin-tazobactam. But 1 month later, when the patient develops urosepsis, the organism is Pseudomonas aeruginosa, highly resistant to all antibiotics tested, including piperacillin-tazobactam. So what could have been done differently in this case? Well, use of a narrower agent rather than a broad-spectrum antibiotic may have prevented this occurrence. A shorter, appropriate course of treatment targeted to the infection the patient had, which was pneumonia, could have prevented this occurrence. And adjusting the antibiotics based on culture results, which should always be done. So that leads us into the objectives for this webinar: to identify appropriate resources for optimal antibiotic selection, to recognize opportunities for antibiotic discontinuation and de-escalation, to understand the impact of de-escalation on clinical outcomes, and to appreciate the appropriate antibiotic treatment durations for specific clinical conditions. So the CDC used to have a slogan called Get Smart, Know When Antibiotics Work. They've changed that slogan a little bit. What's it called now? be antibiotic aware or something like that. But this link still works, cdc.gov/GetSmart, and there are lots of educational materials and campaign materials there. But we appropriated the word SMART from the Get Smart campaign and came up with our own mnemonic, SMART, to refer to these concepts of selection and de-escalation, duration. So as for starting off, choosing the appropriate empiric regimen of antibiotics and maintenance of therapy. So once you've received your culture results, you've assessed the patient's clinical status, targeting that antibiotic to the infection that you're treating, de-escalating to the narrowest possible regimen, and discontinuing therapy if you decide that there is no longer an infection. A, are you treating infection or colonization? R, root, IV versus PO, and you always want to use the PO when possible. And T for time, stopping the antibiotic early as possible. So I'm going to go through the elements of this mnemonic with you today. So S, starting off, choosing the most appropriate empiric regimen. And so the way to think about it is this triad or this triangle where you've got the antibiotic that you need to choose, you've got a disease state that you're targeting, and you've got pathogens that you need to cover. And there are different ways that you can go when you're thinking about this triangle. You can go overly broad, you can go overly narrow, or you can get it just right. And we don't really know in all cases exactly where that sweet spot is, admittedly. And so one needs to really think about what kind of infection am I treating? How serious is it? What are the consequences if I get it wrong? What are the consequences if I overtreat? Those consequences often being resistance and C. diff and side effects you don't need. And what exactly are the pathogens that I'm trying to target here? Are they highly resistant, hospital-acquired types of pathogens, or could I get away with a narrow spectrum regimen? Consequences are going to be higher when you have a very sick patient with signs and symptoms of sepsis. Consequences are going to be lower when you have a stable patient and you can afford to go narrower and shorter with your durations too. So the first question really is, does this patient need antibiotics right now? Can the patient's symptoms be attributed to a non-bacterial condition or a non-infectious condition altogether? So in a patient with dyspnea, shortness of breath, is this just a simple COPD exacerbation, or is this fluid overload and not an infection? If there's rhinorrhea, that's particularly a sign that you're probably dealing with a viral upper respiratory tract infection or a sinusitis rather than a pneumonia. Altered mental status is very often or more often due to things like dehydration, pain, medication side effects, rather than some occult, hard to pinpoint infection. And so watchful waiting is the appropriate response to often to these particular signs and symptoms. When do you need to start with big guns? It is really proven time and time again that using the broadest spectrum antibiotics, if you do that every time, will lead to resistance. So you need to think about the patient risk factors and critically assess who's actually at risk for multi-drug resistant organisms. And so these are some of the risk factors that have been shown in the literature to be associated with MRSA colonization and colonization with resistant gram-negatives like Pseudomonas and ESBLs and Acinetobacter. And you can see some of them are the same and some of them are different. Hospitalization is a risk factor for both and definitely prior antibiotics, right? So although we're thinking about what the patient's risk factors are to determine whether they need big gun antibiotics, we also need to remember that every time we use those antibiotics, we're creating further risk for multi-drug resistant bacteria. And I think, it is true that many of the residents in long-term care that you take care of have one or or more of these risk factors. And so, again, it's going to be a matter of how sick is this patient? Can I afford to start narrower and maybe escalate if they don't respond? Or do I need to go with my big gun right away? So, antibiotic choices for MRSA and resistant gram-negatives. The list on the left, these are all of the drugs that will cover MRSA, some of them being very expensive, some of them being very cheap, and some of them being narrower spectrum than others. And then the drugs on the right are the antibiotics that we use to treat the resistant gram-negatives, and they are in several classes: penicillin, cephalosporin, carbapenem, monobactam, fluoroquinolones, and the immunosuppressants. And again, some of these are narrower than others. Some of these carry a higher C-diff risk than others, and it is admittedly tricky. And that's why infectious disease consultants were invented. So where can you find resources on what the best antibiotic choices are for common infections? This is a website that I go to almost every week, idsociety.org, and we've shown you here this drop-down list on guidelines in patient care and the IDSA practice guidelines. There is a long, long list of disease states, organisms, and hospital-acquired conditions that experts have written comprehensive guidelines for the management of, and I would highly encourage you to use those guidelines in the management of long-term care patients. I am going to now turn it over to Gabriella, and we're going to move on to M. Mamus.
Hi. So now after Sherry just spoke a little bit about selection of antibiotics once you're suspicious that your patient has an infection, then we go to the next step of maintenance and what to do once you started antibiotics. So I'm going to start with a case of this 45-year-old woman with breast cancer who had been in rehab to gain strength after a long hospitalization and chemotherapy. Yesterday, she developed a low-grade fever, and her urinalysis was positive, so she was started on cefepime. Today, her blood pressure is low, and the labs report urine is growing Acinetobacter species. But it will be another 24 hours before, you have susceptibility testing results. So what do? You have this patient in cefepime, and you have a bacteria. So one of the options that you have is your local resistance based on antibiogram. So this is an example of a antibiogram where you can find the organisms and the classes of antibiotics. So if we go into the first row where the Acinetobacter baumannii is, which is what your patient has, you look and see, how the cefepime does with Acinetobacter. Terrible, 63%. That's not a good choice, and my patient already has a low blood pressure. So let's see. What other big gun can I put her on while I get susceptibility testing? What about meropenem? 75%. Not that great either, right? But let's look further into this class of antibiotics, and then surprisingly, you find that ampicillin-sulbactam is 100% acceptable in the isolates at your local hospital. So what do? You should think about switching that cefepime to ampicillin-sulbactam based on your local resistance, based on your antibiogram. So this is how you can easily use the antibiogram while you're waiting for culture results from the microlab. So a little bit about Empiric versus defined or targeted therapy. Empiric is defined as initial administration of broad-spectrum antibiotic regimen that attempts to improve outcomes and minimize resistance. And broad-spectrum is defined as covering the most likely organisms in that disease state. Defined or targeted would be modification of antimicrobial therapy once the cause of infection is identified. Therapy may also be discontinued if the diagnosis of infection becomes unlikely. If you think your patient after 24, 48 hours they may not be infected and something else was causing the syndrome, then you can stop antibiotics. And then focus on the escalation of antibiotic therapy with the goal of minimizing resistance, toxicity, and reducing the risk of C. diff, as well as improving cost and effectiveness. So the M in our acronym, maintenance of therapy, Empiric regimen is not often the regimen that needs to be continued for the full course. You want to get those cultures, you want to use the data to narrow the spectrum as much as possible. You want to get to a diagnosis too, right? Your patient will present with a disease state where they have what seems to be sepsis, but you want to know from whether it's pneumonia, whether it's UTI, or an intra-abdominal infection. You want to get cultures to narrow your antibiotics, and you want to do an antibiotic timeout and reassess in 48 and 72 hours. If you had your patient in broad-spectrum antibiotics in 48 hours, they got better, probably because they're in broad-spectrum antibiotics, but by then, you have some culture data to guide you, or something diagnostic-wise that will help you direct therapy. So in terms of antibiotic timeout, there's different ways you could do it. If you could do a hard stop, basically stop completely the antibiotic, which sometimes can be problematic if you don't have ways for safety, you don't want a patient that's infected not being on antibiotics versus stop. You can do it electronic versus manual depending on the medical record you have at your facility, passive alert versus actionable item, and use all the resources for next steps. Like I mentioned, the anti-diagram, or trying to consult with a specialist, whether it's an infectious disease specialist, an antimicrobial stewardship specialist, talk to your microlab, figuring out what's pending, what are they seeing, and checking always your cultures, making sure that every day you make a habit of looking at the cultures to then target therapy. Also, it will improve outcome if you put the patient in the optimal therapy for the infection they have. So the definition of de-escalation, narrowing the spectrum of the antibiotic relative to clinically pathogenic organisms, reducing the ecologic consequences of an antimicrobial on the microbiota, and choosing an antibiotic with a milder safety and toxicity profile. So you have your patient in the broad-spectrum antibiotics, and you want to think about the consequences of keeping them on them, right? Like Shira was saying, your patient got better in the broad-spectrum antibiotics, but that doesn't mean that that's the best and optimal therapy for your patient. Also, because you can develop other complications such as C. diff. So this is a paper published in the Journal of Antimicrobial Chemotherapy, and it was an interventional retrospective ecological study in a medium-sized hospital where they looked over 6.5 years. The intervention was basically restricting high-risk antibiotics. High-risk were defined as second-generation cephalosporins, third-generation cephalosporins, fluoroquinolones, and clindamycin. And then they had low-risk antibiotics and medium-risk antibiotics. Medium-risk antibiotics were penicillin combos like Amox class or Augmentin and macrolide, and low-risk antibiotics were tetracyclines and vancomycin. So you're looking, this first one is the high-risk group, high-risk antibiotics, and this is the low-risk group. The medium-risk looks similar to the low-risk group, so we just put this two just to compare. Here in this axis, you're seeing the Clostridium difficile infection number of cases per bed, 100 beds, and in this side, the antibiotic use. And over time, between 2004 to 2010. The black line, or I guess darker line, is the antibiotic, the C. diff rate, and the grayish lighter line is the antibiotic use. So as you can see in the high-risk antibiotics, which is the top graphic, as they went down on the use of the high-risk antibiotics, the C. diff rates went down. As they went up in the low-risk antibiotic use, the C. diff rate went down. Hence, the intervention was associated with a significant change in the level of use of high-risk antibiotics, as reflected in the first graph, and the reduction in the use of higher-risk antibiotics was associated with a significant change in the incidence trend of C. diff infection. So in addition, they also improved methods of cleaning for C. diff, but overall they were able to significantly prove that certain antibiotics use will affect the C. diff rate in the hospital. So this is a study just looking at risk factors for acquiring C. diff, and it's an adjusted odds ratio. So the more you're to the right, the higher the odds ratio, and the likelier you are to have C. diff. This is the list of risk factors that they look into, and here are the results. So it's got a little bit malaligned, but I'll go through it. If you look here, illness and facility transfer, and being in the hospital, and being around prior inpatient stay for 3 months, which is this line and this line, make you have a more likelihood of acquiring C. diff. But the interesting finding they had is that multiple drug classes. It was not meant to have vancomycin PO in the square. It's supposed to be multiple drug classes, 1 versus 0, 2 versus 0, and 3 versus 0. So meaning, the more drug classes of antibiotics that a patient has in a given time make them more likely to have a C. diff infection, or a risk factor to have, they're a higher risk factor to have C. diff infection, which argues in favor of trying to de-escalate those drug-spectrum antibiotics as soon as possible in order to avoid for your patient to acquire C. diff, which is another complication, among others, like resistance for your patient. So that was an example, especially in the first study, about how you can sort of manipulate and try to make providers use one class of antibiotic more than the other one. But what are the consequences of actually doing that? Because it comes with consequences, and we call it antibiotic shunting. So there was a paper that they look at restricting cephalosporin use to control total cephalosporin-resistant endosocomial Klebsiella. So this hospital had an issue with resistant Klebsiella, so they decided to restrict the use of cephalosporins. And what happened was that they had 80% reduction in hospital-wide cephalosporin use, with 44% reduction in cephalosporin-resistant Klebsiella, and 71% reduction in cephalosporin-resistant Klebsiella in the ICU, which sounds great. But what was the consequences of that? And it was really unintended consequences. They obviously had increased independent use up to 141% independent use, which consequently caused an increase in independent resistant Pseudomonas aeruginosa, which increased 69%. In the paper we mentioned here at the bottom, Burke in JAMA, it was called antibiotic resistant squeezing the balloon, hence the picture we are showing here. The authors compare medical cost control to squeezing a balloon. Constraining one end causes the other end to bulge. So like in the case of the cephalosporin restriction study, addressing the problem of antibiotic resistance by limiting the use of one class of compounds may be counteracted by corresponding changes in prescribing and drug resistance that are even more omnivorous, thus contributing to antibiotic shunting. So we can really focus our efforts to encourage heterogeneity and making sure that we individualize by patient and by the clinical state that we're seeing at bedside. Getting information, getting cultures when appropriate, making sure that we follow those cultures, working with the microlab in terms of time frame, how long do you think it's going to take for the blood culture or like for you to identify it. Like the microlab can help a lot, using your antibiogram, getting as much objective data as possible to reach the diagnosis that will aid your clinical decision. And hence, you will have better antibiotic selection, better de-escalation, and duration and of course, you will use your resources available, and if you have consulting specialists or antimicrobial stewards, people that are specialized in this type of scenarios, then use them whenever possible. I'm going to shift now to Ira, who's going to talk about getting smart with infection versus colonization.
Thank you. So I'm going to pick up and talk, kind of go through the acronym. We're going to assume that we started off correctly. We're going to assume that we are maintaining appropriately and waiting on cultures. And then we get to the point where cultures have come back. And that's where we get to the letter A. Are you treating infection or colonization? Because we all know that not every site in our body is sterile. And if you culture people's skin or hands or sputum, often their urine, all of these sites may have colonizing organisms. Likewise, if you take if you obtain a culture in a non-sterile fashion, like if you got a little bit of skin contamination into your blood culture bottle, that's what we call a contaminated sample. Both colonization and contamination represent bacteria present in a culture that don't necessarily indicate that there is disease present, and neither of those conditions requires any antibiotics. So things that we can do to prevent contaminated cultures would include avoiding drawing cultures through a central line. There's a study that looked at culturing central lines after they were removed for just being done with needing a central line. And many of them found bacterial growth just from colonization around the line. So we know that taking off of the central line is more likely to give us an inaccurate depiction of the patient's, whether the patient's actually sick. Likewise, urinary catheters are notoriously colonized with bacteria and really aren't reliable for indicating whether somebody has a urinary tract infection. Another way to determine colonization versus infection is looking at whether there's white blood cells in the urine. If there are no white blood cells in the urine, it is almost impossible that the patient has a urinary tract infection, with the caveat of if they are neutropenic and have no white cells in their body. But if the patient is otherwise relatively immunocompetent, and if you think they have a UTI, there should be some evidence of white cells in their urine. Conversely, just because there's white cells in the urine does not necessarily mean that there is a urinary tract infection. It just means that it is a possibility. And lastly, we think of oftentimes bacteria colonizing various sites of our body, but Candida or yeast is also another very common colonizer that is just present and very rarely it causes diseases, specifically in the urine and in the sputum where it gets cultured very frequently. There was a study that was done of a couple hundred patients. About half and half were split of whether they were catheterized or uncatheterized. And all of these patients had Candida in their urine at baseline as colonization. They randomized these patients to receive a 14-day course of fluconazole to treat the yeast or the Candida that was identified in those patients' urine. And you'll see here that after completing 14 days of therapy, the rates of Candida eradication were double that in the patients who got fluconazole compared to placebo, which might make people think, oh, well, giving fluconazole is a good thing. Treating this colonization is a good thing because it got rid of all the Candida. But only 2 weeks later, after completing that course of antifungals, the rates of Candidaria colonization were identical again. So it took 2 weeks of antifungals to remove colonization in some patients, and simply 2 weeks later, the benefit was completely washed out. So therefore, we have identified that treating colonization, specifically Candida colonization, really has no effective role in therapy, and we should just ignore the Candida if we see it on a urinary culture. We've shown this picture before, but we can't show it enough times. Urine is not a sterile site. Urine is not sterile. And the older you get, or the more risk factors you get, the more likely a resident is to have non-sterile urine. Elderly women living in long-term care facilities, 25 to 50% of them are going to have asymptomatic bacteriuria at any given time when you culture them. So if you're trying to work up an infection, there's a 50-50 chance that you're going to find some sort of bacteria in their urine. That doesn't necessarily mean that they're all infected, and very often you can miss the problem at hand by anchoring to this false diagnosis of urinary tract infection. As I mentioned, catheter use presents a large risk for bacterial colonization, with 100% of patients who have a catheter in for more than 14 days developing some sort of colonization with bacteria. So if a patient does have an indwelling catheter and you want to assess whether or not they have a urinary tract infection, it's encouraged to pull the Foley, straight cast them for a urine sample, and only test that second sample, or if needed, replace a new Foley and only test that new Foley sample for bacteria, as opposed to the long-term catheter that you know will have some bacteria that may or may not be indicative of what's actually going on with the patient. So after we assess that the patient does not have colonization or contamination in their cultures, and we decided that we're going to continue treatment with antibiotics, another important thing to consider is the route of antibiotics, whether they're IV or oral. There are many potent and effective antibiotics that are available in the oral route. Using the oral route is better because it's less expensive in many cases. It allows us to get rid of any lines, which can cause a lot of problems, and it can also lead to decreased length of stay for people that might be in skilled nursing facility or rehab that are simply there just to get IV antimicrobials. For the participants that are in Massachusetts, we are largely burdened with the fact that, or actually across all the participants, Medicare doesn't pay for outpatient antimicrobial therapy. So very often, because patients can't get antimicrobials in their home, they have to often get sent to a rehab or skilled nursing facility just to get IV antibiotics. Now, conversely, if there is a patient in one of your rehab or skilled nursing facilities that is getting IV antibiotics as a reason to stay, if a patient needs to be in your facility, switching from IV to oral is not going to put you at risk for having your claim be rejected, as long as there's another reason for them to be there, at which point, if they don't have another reason to be there and there is an oral antibiotic regimen, they should probably not be in your facility. So here I have listed a couple of antibiotics that have fantastic oral bioavailability. I'm sure, and we can say for certain based on some of the antibiotic submission data that we've seen thus far, there's a lot of fluoroquinolone and linase lid use at skilled nursing facilities, and a lot of Bactrim as well, the sulfamethoxazole trimethoprim. As I mentioned, switching from intravenous to oral medication is not only associated with decreased length of stay and decreased cost of care, it also protects our patients from the potential of having any sort of line-related infection or other adverse effects like phlebitis or surrounding cellulitis. There are some other benefits that we see for patients who have fluid or sodium restrictions. Very often, these antibiotics, when given intravenously, have to be in a couple hundred ml,
and be given multiple times a day. For a patient who really just wants to drink a glass of water but doesn't have the fluid to give because they spend all their fluid allocation on IV antibiotics, that's a little bit dissatisfying. And the same for sodium. We forget about the fact that aside from antibiotics being formulated in either D5, dextrose 5% or normal saline, there also is sodium inherently in a lot of these drugs when they're given intravenously that can also take away from a patient's sodium allocation. There is a concept of enterohepatic cycling that occurs only when antibiotics are given orally. If you take an oral antibiotic, it gets absorbed into the systemic circulation. It gets some antibiotics get secreted into the bile and back into the GI tract, and then they can get absorbed a second time. So you're essentially getting more bang for your buck for certain antibiotics that are given orally compared to those being given IV. And lastly, it has been shown on multiple surveys, and not surprisingly, that patients generally have higher satisfaction scores and are happier with their care when they get to take oral medications as opposed to IV medications. It's more convenient for them, it's less invasive, and it's just associated with overall better outcomes. So moving on to timing, we have to think about how long should therapy be, and also think about that sometimes less is more. We've talked a little bit about number of antibiotics using one antibiotic at a time as opposed to 2 or 3 to reduce your risk of C. diff, but also using fewer days of antibiotics can also contribute to lower rates of C. diff. Long gone are the days where we used to think that you have to complete your full course of antibiotics and not miss a single dose, and complete your full 14-day course, otherwise you're going to develop resistance. In fact, I just filled a prescription for my child the other day, and that was written on the antibiotic label to complete the full course. But we're realizing that more and more that the full course sometimes has some adverse effects, and for certain, and I want to highlight, for certain types of infections, treating until the patient is better, is clinically better, is a completely reasonable strategy as opposed to fixating to some arbitrary duration that may potentially expose your patient to more antibiotics than they need, and then conversely increasing their risk of C. diff by exposing them to that many more days of antibiotics. Here is a table that shows how recently we're starting to realize that short course is just as good as long courses of antibiotics for many types of infections. Things like pneumonia, both community-acquired pneumonia and in addition to nosocomial pneumonia. The idea that you need 1 to 2 weeks of antibiotics has kind of been debunked, and there are some infections that can be treated as quickly as 3 days, but with most nosocomial pneumonias being effectively treated within 1 week of antibiotics. Same thing goes for urinary tract infections and significant and intra-abdominal infections, especially when surgical management has been accomplished. Realistically, no more than 4 days of antibiotics should be needed. It is pretty rare that a patient should need more than 1 week of antibiotics, and those cases are largely for osteomyelitis or endocarditis or some major infection. Conversely, if you take a second to reflect about the residents in your facility, think about how often they are on antibiotics for longer than a week. It's probably relatively frequent. So it's something to consider, are there opportunities to cut these regimens a little shorter and protect your patient's microbiome and protect them from developing C. diff and developing resistance and developing adverse effects, because every additional day that a patient is on an antibiotic is 1 more day that they're at risk for developing some sort of adverse effect to that medication. As I mentioned, this is a study that was that looked at patients who were diagnosed with pneumonia and actually had really invasive cultures taken all of these patients had negative cultures, but some people just continued out the 7-day course because they were getting better, and some people discontinued early because the cultures were negative. And looking at the difference between early discontinuation versus completing the course, we find that there was no difference in clinical outcomes, but there was a statistically significant difference in superinfection, with more patients having more resistant infections, specifically multi-drug resistant superinfections, if they had completed the full pneumonia course as opposed to patients who had early discontinuation of their antibiotics within 1 day of the negative culture. Conversely, looking at 7 days of Cipro versus 14 days for urinary tract infection has shown no significant difference in both short-term efficacy as well as cumulative efficacy, looking at later-term outcomes as well. So one of the concerns is that patients may show early signs of improvement if you end antibiotics early, but the infection is going to come back. But even looking at later-term outcomes still suggests that shorter courses of antibiotics are equally efficacious. So I just want to really reiterate all the points that we discussed today about how to really use antibiotics in a way that's smart, starting off with the most appropriate antibiotic for the condition that you're concerned about. As Gabriella mentioned, really doing diagnostics to maintain and appropriately use antibiotics. We think about what is, if a patient seems sick, they should probably have some sort of a diagnosis as opposed to just sepsis or fever, but really identifying what is the presumed body system that is infected, what are the bugs that cause infections in that system, and then making sure that we're appropriately culturing and targeting antibiotics to that site and type of infection. We need to constantly reevaluate via antibiotic timeout whether we are appropriately treating an infection as opposed to treating colonization or a contaminated culture. We should be switching to oral antibiotics as soon as possible just because of the beneficial outcomes associated with using orals as opposed to IV medications. And lastly, we should be stopping antibiotics as soon as possible to ensure patients aren't exposed to additional days of unnecessary antibiotics. So with that, we encourage you to be smart with your antibiotics and continue to reevaluate all of your therapies as you continue to need to treat these infections before we develop so much resistance that we run out of our antibiotic options. So with that, before we do Q&A, I'm going to pass it back to Alazy, who has some announcements.
All right. Well, thank you, Shara. That was great. We are now opening up for some questions. And just a reminder, please press #6 to unmute yourself and ask any questions over the phone. Or you are welcome to enter your questions over to the chat box, and we'll read them out, and we'll have a discussion. So we are welcoming some questions. Any questions at all over the phone? Okay, since we don't have any questions, I will move on to our closing slide. And if you do think of any questions while you're reviewing the webinar slides, feel free to shoot us a quick email with your question, and we'll definitely forward it to our speakers, and they will be able to answer any of your questions. Please don't forget to mark your calendars with the remaining webinars for this series. We have 2 more on August 14th and September 11th. You can check out our website for more information. As a reminder, we would like to thank those nursing homes participating in the New England Nursing Home Quality Care Collaborative who have been actively engaged in the collaborative activities and committed to quality improvement. If you have received your badge, and we're asking you to share your commitment to quality by posting a photo of your badge displayed in front of your entrance and posted on social media with the hashtag @WeCommitToQuality. And don't forget to tag the New England QIN-QIO on Facebook, Twitter, or LinkedIn. And later this year, we will be announcing the award winners. The New England QIN-QIO continues to spread best practices throughout nursing homes in New England, and we are asking you to share your story. We will be highlighting a success story of the month on our monthly newsletter, The Wink, and highlighting your success story with CMS. We would like to thank Hanover Terrace and Riverside Health for your commitment to quality improvement. They have posted their badge in front of their entrance. Make sure you take a photo and share it with us on social media so that we can celebrate your commitment and your success. And lastly, this is our state lead's contact information. If you have any questions regarding today's presentation or the We Commit to Quality commitment to the awards program, if you have any questions at all, please feel free to give us a shout out, and we can return your email and discuss any information that you have regarding today's webinar. And again, thank you all for joining, and have a great day.
Susie, before we close out, we do have a question in the chat box.
Oh, perfect.
So I'm just Karen asks if giving macrobid 100 milligrams is appropriate for just for 3 days to a patient with suspected infection, but if the patient has no fever but has dysuria, if their white count is normal, if they seem relatively well, this seems like the type of patient in whom a watchful waiting strategy could be appropriate, depending on how uncomfortable they are, depending on the magnitude of that dysuria. If they're able to kind of sit tight for a couple days waiting on those culture results and evaluating if it resolves on its own, that would be a perfectly appropriate strategy. Remember that many patients that have urinary tract infections will resolve on their own. I'm not going to advocate for never treating anybody because, it can lead to sepsis sometimes, but in a patient who seems clinically stable, it's very appropriate and very reasonable to sit and just watch them, hydrate them, do the culture, see what comes back, and largely in that 3 days, not only while you're waiting for the results to come back, you're also waiting to see if the patient just resolves on their own.
And a couple other issues one could address with that case. One is the question of treating a urinary tract infection without doing a culture. And we talk about that a lot because in an outpatient setting, that's done often, right? That's done over the phone. I personally think when you have the patient or resident right there, active in your facility, it's beneficial to use culture data to guide therapy. If you do feel that because of patient discomfort you want to start antibiotics, empirically we do like macrobid or nitrofurantoin as an empiric agent. It covers most of the organisms that cause infection. It has somewhat of because it concentrates in the urine and doesn't have a lot of systemic, it doesn't have high blood levels. It doesn't have as much what we call collateral damage as some of the other antibiotics. May not affect the gastrointestinal microbiota as much. Generally, though, even for treatment of a simple bladder infection, the duration, if I'm not mistaken, is not 3 days. 3 days would be the duration that you would use if you were using something more systemically active like Bactrim. We have another question here about when a patient has been diagnosed with being colonized with an infection, is it ever okay to take them off precautions? This is the most common question that we receive in doing this type of education with long-term care. And it's the most difficult question to answer. I've addressed this question in a number of different ways in the infection control webinars as part of this series, and I encourage you to
look at the slides, or even better, listen to the recording from those webinars, because the answer is not clear-cut, and the guidelines from CDC are not clear-cut. The short-ish answer is that each facility is allowed to develop their own policies around isolation or colonization and even infection, with the exception of carbapenem-resistant Enterobacteriaceae. And so when it comes to MRSA and VRE, which is usually what we're thinking about here, many facilities are not isolating patients who are simply colonized with those bacteria. Many facilities are not even isolating patients who are infected by those bacteria. Certainly if you think about patients who have a VRE bloodstream infection, for example, they're not more likely to transmit that infection than somebody with a VRE colonization in the GI tract. So this is somewhere where you might want to access expert guidance, expert consultants as you develop and enhance your policies and procedures.
So the next question is from Amber regarding a patient who was recently admitted but has a history of C. diff and is on vancomycin 3 times a week for quite some time, asking about the efficacy or appropriateness of this. So, for a long time we didn't know the answer to that, and up until only recently do we have a better sense of how effective vancomycin prophylaxis is for C. diff, and the answer is it's not great. Although not necessarily 3 times a week, but at least taking vancomycin daily seems to prevent C. diff. But then what we found is the second you stop the prophylaxis, the patient is at even higher risk for C. diff than they were if they never got any prophylaxis at all. Because essentially this oral vancomycin is really clearing out patients' gut flora and really selecting for the organisms that can survive with vanco, which includes C. diff spores. So we do encourage facilities not to use C. diff prophylaxis because the efficacy really isn't strong, and the newest guidelines for C. diff discourage using prophylaxis. Next, we have a question for Jessica about prophylactic antibiotic use for urinary tract infections. This is something that has also been studied, and the outcomes aren't great. Very often patients will be on prophylactic prostaglandin or nitrofurantoin. The evidence is weak. It does suggest that there may be some benefit, but it's weak evidence, and you really want to avoid this unless patients have really so many urinary tract infections that it becomes that it's really problematic to their lifestyle. It would be better, if possible, to just only treat urinary tract infections when they truly come up and they truly are urinary tract infections, as opposed to identifying asymptomatic bacteria multiple times while a patient is in your skilled nursing facility.
Right, and to add to that, trying to figure out what are the factors and or symptoms that the patient really think may be associated with urinary tract infection. Most of the time, like with the first question, the patient may say they have dysuria, but there's other reasons to have dysuria also other than a urinary tract infection. And especially if your urinalysis has no bacteriuria, no positive white cells, then you have to look for an alternative diagnosis for their symptoms. When you get at the point where you're thinking about antibiotic prophylaxis for UTIs, you really have to think about whether they really had UTIs or whether it was actually just multiple urinalysis with asymptomatic bacteriuria, which happens in the community a lot, where people are on prophylactic antibiotics for UTIs based on positive cultures, which doesn't necessarily mean UTI. It may be colonization, because we know that urine is less sterile, especially as the older you get. So So once you get to the point where you're doing antibiotic prophylaxis, I would consult with experts about the field because there's really weak data on this, and there's no right or wrong answer. But like I said when we're talking about maintenance, trying to individualize each case and making sure you have all the resources available in order to make a decision that's best for your patient.
All right, well, with that, thank you guys all for your questions and your attention, and we hope you have a great day.